Hello, everyone. I'm Marcel Vanderweer, the editor of OHS Canada. Thank you for joining us today for this important conversation. Today's webinar, Considerations in Effective Policy Development for Addiction and Mental Health in the Workplace, will provide individuals and organizations with practical information on comprehensive policy development, the value of referring to high-quality treatment, and the importance of return to work planning and monitoring. If you have a question during this presentation, please type it into the GoToWebinar interface, and we'll ask it during our Q&A time following the presentation. If you'd like to watch the presentation again or share it with a colleague, a recording of today's presentation will be emailed to you in 24 hours. With that, I'd like to introduce Darren Taylor. Darren is EHN Canada's National Director of Business Development. He is a board-certified interventionist, a master therapeutic counselor, and a Canadian certified addiction counselor. Darren possesses broad knowledge of the addiction treatment industry and workplace substance abuse policy. Over to you, Darren.
Thank you very much, Marcel, and thank you everyone for joining us today and taking time out of your busy schedule. I'll take a minute and maybe share something about who I am and how I ended up getting here and doing this type of work. I came to EHN Canada last year from after 15 years in private practice. So in practice as an addictions counselor and a working clinical interventionist, we also operated two busy occupational health clinics where we did a lot of testing and assessment work for industry. That led into a career doing SAP, substance abuse professional work, working closely with industry, developing policy, managing workplace policy around substance use and mental health issues. And then when I came to EHN Canada last year, in this role, our business development team, we work closely with organizations that refer patients to us and trust us with their people to help them overcome mental health and addiction issues. More and more, the reality was that it's as much as we, certainly we would like to be your provider of clinical care, your provider of choice. We provide exceptional programming across the country, but really more and more the conversation that our people are having with organizations is about, before we get to that place of patients coming for care, what do we need to do? What can we be doing better? What could we be doing differently to improve the bottom line of our organization, improve the wellness of our people, and really streamline and button down that process for identifying, helping, and getting our employees back to work. So there's a big part of this role, and the role that people on our team is helping organizations with policy issues. So this talk was born out of that work that we do, and our goal today is to really we only have 45 minutes. So my hope today is to identify some of the policy issues that are a big part of the conversations we have with employers, with an eye towards helping you perhaps identify things that you're doing well, things that your organization could be doing better, things that maybe you're not doing, and you have a blind spot. We hear that a lot. I'm a big believer in the expression, we don't know what we don't know. So when we're working with companies on this sort of policy stuff, it's not unusual to really come to the conclusion that we didn't even realize that we weren't doing this, or that we could be doing it differently. And the landscape of the continuum of care and the options available to employees and the types of issues affecting our workforce is continually changing. And the best that we can be open-minded and willing to sort of reevaluate on the fly what we're doing tends to serve everyone well. I'd like to start by talking a bit about what we're dealing with and the scope of of the problem and the issues in our workforce. When I'm doing this presentation live, this is the point where I would typically ask for a show of hands about individuals who are participating, their level of awareness, or if they believe that substance use and mental health is a big problem in their workforce. I suspect that with health and safety professionals here today, I'm preaching to the choir. But just to put the magnitude of the problem in context, here are some talking points and some statistics that really have stood out to me over the years. I think the conversation has to start with an acknowledgement that the problem's there. We know statistically, the number that keeps coming up is approximately 5% of Canadian adults relationship with mood altering chemicals, alcohol, or drugs meets the criteria for substance use disorder. So the growing scope of issues with addiction, with depression, anxiety, and other mood disorders aside, just addiction alone, you've got 5% of adults on that continuum struggling with substance use. If we extrapolate that and think of the impact on spouses, children, parents of people, the number really begins to compound itself, so that we have a significant portion of our workforce whose life is impacted by either their own substance use problem or someone close to them who has a problem. And we know that impacts their performance and their ability to give you what they could be giving you. The bottom line cost for organizations is often a big part of this discussion around policy, because as occupational health professionals and human resources professionals in companies, the concept of doing better is really top of mind and easy to understand. The case has to be made to the CFOs, to the bottom line, person responsible for rolling out and absorbing the costs of providing care to employees. 30% of disability claims we know are related to mental health or addiction disorders. Now, as we go through here today, you're gonna hear reference to mental health and addiction disorders, and sometimes I get feedback at the end. Darren, you talk so much about addiction, but what about mental health? The reality is, let's understand that addiction disorder is a diagnosed mental health disorder. It's identified in the DSM-5. And what we know about from the patients we treat is that often these things are all weaved together. Substance use, co-occurring mental health disorders sometimes occur together, sometimes they occur in isolation. But for most patients, it's a complex, sort of weaved in mix of the two of them. 30% of claims, that's high enough, right? But 70% of the cost of disability claims is attributable to mental health and addiction issues. Why is that? The more work that we do with disability insurance providers, what we're learning is that claims for mental health issues or substance use issues tend to last longer. The incidence of return to work and staying back at work are less. Compare it to an employee with a broken leg. They're going to be off for a certain amount of time. They're going to heal. They're going to come back. You've got the employee back that you had before they were sick. What we're learning more and more, and we're working with insurance underwriters to proactively intervene on these situations, is that mental health claims tend to languish. So large organizations describe problems with employees going off on stress leave, mental health leave, leaving for substance use issues, taking a long time to come back to work. And if they do come back to work, there's issues with them staying back at work and staying healthy. And I think I just want to go back to the impact on families and the broader meaning for that in your workforce. If you think of, I think it's easy to sort of envision the stress and the productivity impact on an employee who's battling substance use. But If you have an individual working for you whose husband or adult child is battling addiction, guess what? You're not getting 100% of that individual. Their performance is impacted. Their ability to thrive and contribute to the level that they're capable of is impacted as well. So it's important that any strategy look at providing care and being equipped to intervene and respond to the needs of those individuals as well. So we talked a bit about the cost of businesses related to disability claims. I think that one is an easy issue to put a number to. Uh, uh, Most people on this call today will understand the impact of safety issues, and the issue of safety related to substance use and mental health impacted employees. It's not just for safety sensitive workplaces. It's equally hazardous and potential for significant problems in white collar office environments, as it can be in an industrial or warehouse sort of setting. Absenteeism, loss of productivity. I get that I'm preaching to the choir on that on this call. These issues are real. I think that one of the things we're going to talk about throughout this presentation is the impact on workplace culture. We used to talk about that as what are the intangible impacts of having people in the workplace who are impacted by substance use, who are struggling with mental health issues? What does it do to the culture of our workplace? The reality is, and let's be honest, if we're working next to a coworker who has a chronic alcohol or drug problem, that individual can be difficult to work with. If we're a supervisor and we have a team of people that we're relying on, and someone slides into struggles with depression and chronic anxiety issues, very difficult to deal with, because the level of unpredictability, the number of difficult interactions begins to increase. And what can happen is the atmosphere in the workplace and the workplace culture and the satisfaction level of your employees can be severely impacted. I mean, the good thing about that is by shifting the way that we handle these issues and creating a cultural shift, we can really remedy that and create a workplace that people want to be in. People who are healthy and well, you're getting the most out of those people as well. So the solution lies in taking a look at how we can best respond to the needs of our employees. So typically, the first conversation here would be about, what do we do if someone shows up intoxicated? Take it from me, as someone who has worked with employers for many years, that is the rare incidence. If you have an individual in your workforce whose relationship with substance use, with pills or with alcohol, has progressed to the point where they're showing up intoxicated, that's on the far end of the continuum. That's an employee in crisis. That is a rare incidence. It's not the preponderance of situations we're going to be dealing with, but nonetheless, we have to be willing to develop policies to deal with that. We also want to talk about how do we handle it if an employee steps forward and finally gets to the point where they say, you know what, I think I need some help. I'm struggling with this, or I'm struggling with that. What do we do? And the other issue is how do we handle a crisis in the workplace? So building out policies around all that, turning over stones and thinking about scenarios that maybe we haven't thought of is really the work that we do with employers to help them craft policy that's effective for them and meets the needs of their workforce. Often when I'm doing this talk in person, I'll field questions about, we'd like to we'd like you to help train our employees to identify people who are struggling, or to really look for symptoms and signs and how to help them. That's important, and we do that kind of training. Um, the struggle with that particular issue is twofold. One, most people who are battling the issues that we're discussing, very difficult to tell. These things simmer under the surface, difficult to tell. The other thing is they say, Darren, what does it look like when someone is addicted to fentanyl? What does that look like? Well, there's no quick answer to that, and the reality is, it looks like a lot of things, and sometimes an individual who's battling, um, battling grief over significant loss in their life can appear as irrational and dysregulated and difficult to work with, as someone who's intoxicated by the use of mood altering chemicals. So we want to be really careful as health and safety folks and people who work in human resources. Let's be realistic about what are our expectations of those on the front line supervising employees, and what are the expectations on our own people to identify, to assess, and to step in. What we don't want to do, and human nature really allows this to be a problem. We don't want to put our supervisory and management level people in a position to play therapist, to play counselor, to consult, and to solve the problems of people working for them. I think the way that I like to look at it is, if we're going to train our supervisory level employees, let's train them to be an effective conduit towards a system of care that can kick in and do what needs to be done. And I hear the same thing really from mental or from human resources departments. Even the most experienced human resources professional is not equipped to unbundle and immediately intervene on someone before them who's in acute crisis with addiction or chronic anxiety issues. But what we can do, if we've done the work in the background to build an apparatus that can jump into action quickly without delay and effectively, is train that human resources department and your health and safety teams to be a conduit to introduce them to a seamless system of care. And I think that's what we're going to get into here is trying to build that, and what does that look like, and how could we maybe be doing it differently in our organizations. I mean, some of these warning signs are obvious and they're stereotypical, but boy, oh boy, I mean, someone presenting with behavior characteristics of mood swings, irritability, anger, bad attitude, they could be addicted to drugs. They could also be going through a divorce or going through a financial crisis. It's difficult to discern, and it's unrealistic to expect that we're going to be able to discern that on our own. So, I mean, a good rule of thumb is, we don't want to assume an employee has a substance use problem, and understand that these things are complex. They don't always present as they appear, and to, always, do our best to work and act objectively. Let's start with the idea of self-disclosure in the workplace. This idea that we're going to have individuals in our workforce who step forward and ask for help. There's two issues here, really. What can we do to improve the culture where employees feel safe and are willing to step forward and ask for help? And what can we do to improve the apparatus that kicks into place once someone does ask for help? We know that in the workplace, I mean, as much as we talk about stigma and the reduction of stigma, as much as the Bell Let's Talk campaign goes on year over year. Mental health issues, by and large, are not looked upon the same way that we look at physical disabilities or other health issues. Uh, Patients we work with describe being bullied, described being ridiculed, devalued, marginalized, and their career being negatively impacted compared to, in their perception, if they were stricken with cancer or another sort of physical health issue. The more that we can do as an organization to create a culture where the stigma is reduced, self-disclosure is it's confidential, the process is respectful, the process is easy to access. Word gets out, and any effective policy development strategy, as time goes on, you will see the number of self-disclosures for addiction treatment, for mental health care increase, sometimes significantly. I'm thinking of a large timber company in Western Canada that I worked with them to sort of build their policy from the ground up. And one of their goals was to incentivize and increase self-disclosure in their organization. And what they saw was a rapid uptick in the number of self-disclosures. Of course, the immediate concern is the cost of caring for these people. Well, but what began to happen is these people got back to work healthy, and other employees saw that, wow, asking for help pays off, and there's systems in place to support our people. So we want to make sure that there's a really clean, user-friendly, effective apparatus to get employees in front of the help they need as quickly as possible, with a strategy to get them back to work. So, I mean, I'd encourage you to ask yourself at this point, what does that look like in my organization? Is it user-friendly? Are we doing our best to reduce stigma? And are we helping employees access the care that they need? Boy, any one of these topics could be a presentation on itself, but I don't think any conversation about effectively handling, specifically substance use in the workplace, the conversation is not complete without really addressing the role that drug testing plays in our policy development. I want to talk about 4 specific instances where organizations are using testing effectively to improve the wellness of their employees and keep their workplace safe. Now, pre-employment is it's handled differently in different parts of the country. The last time I gave this talk, I got lots of questions about the legality of pre-employment testing. When can we do it? Under what terms can we do it? And what are we allowed to test for? And what does that look like? I can tell you that across the country, it is being widely done. It's done much more frequently in safety-sensitive workplaces. Generally speaking, it's done more frequently in Western Canada than in Eastern Canada. I would not discourage you from investigating this. I think part of the conversation is always going to be seeking legal counsel and talking about how and if we want to do pre-employment testing. And the benefit of pre-employment testing is obvious. We can't tell by looking. We can be interviewing a rock star and ready to hire somebody. You cannot identify by looking at someone if they've got a substance use issue. So it's a way of preemptively sort of mitigating our problems down the road. But anytime we're developing policy around this, we want to seek legal counsel. I recently spoke with a lawyer who works in this space, and the feedback I got was there are issues around sort of when we do it and how we do it. So timing might be everything. And reasonable cause testing. Now, this is as simple as, what's our policy if someone shows up intoxicated? If we have someone in the workplace who appears, they smell like alcohol, they're stumbling around, they appear to be under the influence of alcohol, what's our policy? Same thing with use of other drugs. You might not be surprised that, I'll often hear, well, we pull the person aside, we call them a cab, and we send them home. So the problem with that is, more often than not, you're going to have that individual come back to work the next day. We call them into the office and say, hey, listen, I want to talk to you about yesterday. You were here and you were drunk, and we're concerned about you. I wasn't drunk. What are you talking about? I was fine. I was just overtired. Um, Reasonable cause testing is uh, is done as a way to effectively, unbiased, in a non-discriminatory way, step in and verify suspicions. So typically, the way this is done is in a clearly defined written policy that all employees are aware of. In the event of suspected intoxication, an independent qualified third party is called in to conduct a test, maybe a urine test, maybe a saliva test, because we want to be testing for metabolites as well as parent agents. The difference being, are we testing to see if the individual has drugs in their system, or are we testing to see if they're acutely intoxicated at the moment? They're two different tests. So seeking advice and building that policy in a way that's effective is important. And you can't have reasonable cause testing if you don't have a mechanism clearly defined what happens if they test positive. Because addiction and mental health disorders are protected. They're an identified disability. We have a duty to accommodate as employers. So that would lead into a conversation about what happens if they test positive. So we can't do this in isolation. We have to think through the entire policy. Random testing, not widely done in Canada. It's except in the instance of highly safety sensitive workers. With my company, we've done random testing, for instance, on cross-border truck drivers, crane operators, situations like that, where it's a condition of employment. Post-incident testing, widely done in an effective way in safety sensitive environments. And typically what that looks like is employees, if there's an accident, large or small, someone's cut, someone's injured, someone drives a forklift into the side of a truck, everyone who's involved with the incident quarantined. Testing is done again, like what type of testing for metabolites, parent agents, and testing. Drug testing is not drug testing. With the number of different medications that people are inclined to abuse, and the different types of opioids, for instance, getting effective advice on just what we're testing for is important. Someone can be severely intoxicated by a synthetic opioid, for instance, and they'll show negative on a 5-panel or 7-panel drug screen. So what typically is done these days is an extended panel to test for synthetic opioids. It's not as simple as it sounds, and seeking good advice and having sound, consistently applied policy is very important. In my experiencing managing policies for employers, if we're building out a policy, we've got our self-disclosure strategy well defined. We have a policy that we're comfortable with around reasonable cause, acute intoxication. The post-incident testing is going to be over the course of a year, will typically be where the majority of your that's called impatients are going to come from. So if we're managing a program for a company with 5 or 10,000 employees, there's some office workers, some safety sensitive, some warehouse, some industrial employees sprinkled across the country. They've got all this apparatus in place, and we're charged with conducting an assessment anytime someone asks for help or fails a test. We're going to get more referrals as a result of post-incident testing than we are from all the others combined. Your incidents in a workplace is typically going to see very few reasonable cause situations. You're going to see a good number of people asking for help if you've got an effective user-friendly policy around self-disclosure. But this is where you're going to see it, especially in any sort of industrial environment, is on post-incident. So having a clearly defined, clearly uniformly applied policy around that is important. But again, it's not just the testing. It's what do we do and how do we do it if they fail a test? Where do we send them for an assessment? Do we want to send them just off to their GP, or do we want to get them in front of a qualified professional that we've hired to conduct an assessment? Any of those three streams into your mental health and addictions policy ought to require formal assessment. Even over the years, even large, sophisticated employers, household names, companies with employees right across the country, this is a really common blind spot. And I've at large companies. What's your policy around this? Well, we're willing to help people and support them. Well, what do? Well, we send them to their family doctor. The reality is, GPs in Canada, or GPs mostly anywhere, are not trained to conduct assessments and prepare treatment plans, especially to meet the needs of employers. So what can happen is, if I go to my family doctor and ask for help because I'm battling alcohol, there's two problems there. One, I'm putting an onus on a physician who's not trained, who doesn't work in that space. I asked my own family doctor when I was doing this work, if someone came in and asked you for help, could you identify 3 or 4 addiction treatment programs, the difference between the programs and their different costs? So, well, of course not. Well, I wouldn't even know where to start with that. That's not what they do. The other problem is, we've got an employee who's now in a position of driving the terms of their care. Someone who's in crisis, someone who, by virtue of their own health condition, is arguably not equipped to be making good decisions for their own care, is now put in the very stressful role of having to navigate this and drive this themselves. Best practices would suggest that assessment should be done by a qualified professional in a prompt manner. Traditionally, these assessments are done by an IME doctor to conduct an independent medical evaluation, and that doctor would provide a diagnosis, a description of what a clinically appropriate care might look like, and also recommendations for what return to work might look like. So there's two issues with having, I can point you in the direction of qualified IME docs. These doctors are sometimes difficult to access, and these assessments are very costly. More and more employers are using a combination of IME docs or the firm that they've hired to manage this on their behalf, using IME docs, also using other specially trained mental health professionals to conduct these assessments. We did them in my clinics, in my private practice, with master's level clinicians, experienced at conducting assessments, preparing treatment plans, very quicker turnaround and a lower cost, with an understanding that there's always going to be situations where we've got to bring in a psychiatrist or an addiction doctor. But as employers, as health and safety professionals, your goal here is this: in a prompt, user-friendly way, get your employee in front of someone who can conduct an assessment, typically 2, 3, 4 hours in length, and provide a written report to you that includes information. What is this individual suffering from? What does clinically appropriate care look like? And what are our recommendations post-treatment and return to work? All that information should be in there in that report as a roadmap for the employer to walk through. And then it also gives employers something to fall back on to require that the employee follow through on. So I think you're beginning to see the theme here is that each of these things leads into a combination about the next thing. So having an effective testing policy, a funnel into the care, you've got a competent organization in place to do your assessments. Now what? Um, where do we send these people for care? Who pays for care? How do we get them into care? How do we know that they've completed care? What does that look like? The this is where the conversation is invariably going to come around to what do we have in our benefit package to provide financial help for accessing care? What is the employer willing to do, and how creative can we get about sharing the costs of care? So when we talk about clinically appropriate care, so if you think about heart disease, for instance, if I'm suffering from heart disease and I go to a cardiologist, what are they going to do? They're going to evaluate my needs. They're going to determine where I am on the continuum. How bad is it? You know, am I going to get the diet and exercise lecture? Am I going to be, maybe they're going to prescribe me statin drugs and ask me to lose some weight? Or maybe we're talking about a severe intervention, progressed heart disease, where the recommendation is quadruple bypass surgery. So in that instance, I think it's really easy to understand that if someone needs bypass surgery and we say, well, bypass surgery is expensive, there's long wait lists, so we're just going to put you on a statin drug and hope that it cures itself. We would never ever do that. Patients would die in that environment. Um, so we wouldn't accept that as appropriate. Unfortunately, with mental health care, that's often what we do, especially in the public system. That's what care looks like. It's resource based. It's not needs based, based on what the patient needs. So as employers who have a duty to accommodate and who have a vested interest in the employee getting well and getting back to work and being healthy and productive, getting them, I think you're beginning to see here, right? You know, are we talking about someone who has an episodic issue with grief or with stress management or marital issues? Is counseling the appropriate intervention? Do they have a mild substance use disorder and are a really strong candidate to respond to intensive outpatient treatment for their substance use issue? We're doing a tremendous amount of that at EHN. Our outpatient programs, virtual and in person, are a growing part of it. Why? Because companies are learning the benefits of intervening early. They can get patients into an effective outpatient program and get them back to work with a much lower treatment cost. Or does the assessment indicate that the individual has to go to a residential addiction treatment program or to a residential program for a severe mood disorder? And even within that space, we need expert advice here, because a treatment center is not a treatment center. Unfortunately in Canada, in many jurisdictions, it's largely unregulated. So the internet is the Wild West. Employees looking for addiction treatment can find them in front of a facility who's simply not equipped to meet their clinical needs and to help them get well. So I mean, the goal here is to optimize outcomes. I can't stress enough the importance of assessment, and getting a roadmap and understanding that unless we know what the needs of the patient are, because we can't rely on the patient to tell us what they need, because one of the symptoms of addiction, for instance, is the patient's growing inability to have this level of self-awareness around their own state of being and the seriousness of their own condition. A psychiatrist who I mentored under, one of the things he used to say, I'll never forget. He said, Darren, one of the things that's the matter with him is he doesn't know what's the matter with him, right? So again, we don't want our employees be the ones driving this bus and dictating it. We want to fall back on professional advice. And that protects the employer in the long run, because it allows us a roadmap. It's perilous to simply send someone off to access their own care, and then we get a phone call in human resources saying, yeah, I'm all good, I completed my program, I'm good to come back to work. Well, as health and safety professionals, how do we know? Like, how do we know that they've done what they, how do we know that they're better? Um, we really have an obligation to our broader workforce, don't we, to have something in place to let us know, in writing, the individuals completed the recommended programming. They're fit to return to duty, and these are what we recommend going forward. And this is where you would have a conversation around the return to work protocol, modified duties, coming back part-time, able to do this, not do that. Maybe someone completes a program and the recommendation of the physician is that they plug into some outpatient care and not come back to work for 3 to 4 weeks. Also, this is where it would be identified what the follow-up or monitoring protocol might look like. I feel like we're going through this fast. Some of these issues, I'm sure your companies are doing a great job of, and some of them you might be sort of scratching your head, wondering how we can be doing better. Please don't be afraid to reach out to me, and we can dive into any one of these topics on their own. I want to talk briefly before we dig into post-treatment about funding treatment. The way that organizations fund treatment varies greatly. More and more companies are seeing the bottom line benefit of funding care 100%. We're also seeing a trend towards cost sharing, towards a couple of organizations I work closely with, for instance, they provide interest-free loans to employees to help pay for clinical programming, repayable over a number of years. And not only that, they're providing incentive if the individual successfully completes a 2-year monitoring program, for instance, they're forgiving a portion of that loan. All right. There's, and I can help you make a case to your organization about why some of these initiatives really might make sense. The costs of not getting people back to work, having to hire and train and integrate people back into the hard costs and the intangible costs and the impacts on culture are significant. So aftercare, this slide came to me courtesy of Dr. Adams, a really well-respected workplace addiction doc in Calgary, but it really is applicable to a lot of mental health programming as well. It talks about, and what we've known as addiction professionals for years, if we just take a person, plug them into a treatment center, and have them come back after 30 days and slide back into their old life, the recidivism rate, the recurrence of symptoms, the relapse rate, call it what you want, is significant. And it's not unusual at the beginning of these conversations for employers to be really cynical and say, Darren, we've paid for people to go to treatment. Treatment doesn't work. People, they relapse. We end up firing them anyway. What we know is that treatment on its own is not enough. There's a reason why airline pilots, why physicians, why safety sensitive workers and nurses, the recommendation from their IME docs and from their assessing professionals lays out a 2 to 5 year plan. So Dr. Adams tells us, in his experience of doing this for 30 years, a 30-day program followed by nothing, 3/4 of the patients are gonna relapse. You add in a mutual support group, you get them going to AA, Narcotics Anonymous, Smart Recovery, the outcomes improve significantly. You add into that a year of aftercare groups that are like all of our programming at EHN provides, for instance, where we're getting them connected once a week with a peer group of other individuals they went through treatment with, someone to hold their feet to the fire. The relapse rate begins to drop. We're seeing 75% success rates after 1 year. But you stack on top of that contingency planning, compliance monitoring. This looks different for all organizations, this compliance monitoring. When we were doing monitoring, sometimes it was a once-a-month check-in. How you doing? How you feeling? You managed to stay sober? Are you going to meetings? Do you need any help? Do you need to talk to a counselor? those check-ins improve your outcomes even further. You stack on top of that, if your assessing clinician recommends random drug testing, listen, these layers of accountability improve outcomes. Each one of them itself is not a solution. Sending someone to AA is not a solution. Sending them to a 30-day treatment program is not a solution. But you stack these things on top, one on top of the other. They're seeing a counselor. They're going to aftercare. They're peeing in a cup. They're going to AA. They got a sponsor. Guess what? These are going to be your rock star employees. They're going to get back to work, and they're going to be healthy and well, and they're going to be beacons of hope and shining examples of the effectiveness of the program that you've built in your organization. I mean, the things that I've seen with effective peer programs, they blow my mind. I mean, talking to some of these people brings tears to my eyes. The way that they go back into the workforce and integrate and are an example of what healthy change can look like. And I think that's our goal, right? We want to raise the bar. I just touched on compliance monitoring. These are some of the things that we want to talk about. Are we going to have them pee in a cup? We want it to be confidential. We want this to be done by an independent third party. Okay, your HR people can't be doing your compliance monitoring. We also want to have clearly defined policies on contingency. What happens if there's a relapse? What happens if there's a recurrence of symptoms? You know, we hear a lot in addiction and mental health care that, you know, relapse and recurrence of symptoms is part of the condition. It is part of the condition, but there's a way that we can plan for it, and we can effectively, proactively work to provide those layers of accountability to optimize results and have clearly defined ways to handle any sort of contingency in a non-shaming, effective way. You know, I've had individuals who have effectively gone through treatment programs, were a year into monitoring, they go through a divorce or they lose a parent, they have some kind of tragedy in their life, they have a setback. Because we're doing the monitoring and we're checking in, these things don't simmer under the surface. They rise to our in front of us, and we can act accordingly. I can't say enough about the effectiveness of monitoring. You know, so if you want to talk about, you know, anything you saw here that you want to learn more about, or if you're doing something in your organization that seems to be working and you want some feedback on perhaps what could be done differently, you know, I'm here. This is such a short presentation. You can call me, you can email me. As you can probably tell, I love talking about this stuff. I'm passionate about it. You know, I came to this work through my own struggle with addiction and alcoholism. I was that employee who flew under the radar. You know, I was high achieving, but my employer didn't realize that some days he wasn't getting 10% of me. This work is close to my heart. And if you want to talk more about, you know, what you could be doing differently at your organization, I encourage you to reach out. Thank you for your time. Back to you, Marcel.
Thank you, Darren. That was a very informative presentation, which I can tell you're passionate about. We do have a few questions from the audience, and I'll roll through them individually. Darren, someone asks, you use substance abuse professionals for assessments. How do you manage all the mental health diagnoses that usually go along with addiction problems?
Yeah, that's a good question. I think it really comes down to having a qualified professional do it. The people who conduct assessments, for instance, at EHN, are master's level clinicians trained at assessing, identifying, and preparing treatment plans for not only substance use, but co-occurring mental health issues. I think the part of the confusion may have come from this term SAP. It's an industry word, SAP, substance abuse professional. Perhaps that's the wrong acronym. I mean, my company provided SAP services, but let's make no mistake, many of the assessments were for mental health issues. and any mental health professional, and any physician for that matter, if anything is in front of them that's beyond their scope of practice, immediately the assessment would stop and be referred up the chain to someone with a higher level of training.
Thanks, Darren. The second question is, can you do an assessment and monitor the employee, or is there a conflict there?
That's a good question, and it's a timely question. There's a lot been written lately about IME doctors who also are also doing monitoring on the back end. Um, I've seen it done for so long and seen it effectively done for industry so long that, until the question was raised, I never really had an opinion on it either way. Um, I think it's worth having a transparent conversation with your provider of care. But I think my short answer to that is that there are so many exceptionally qualified professionals that are conducting both effectively for employers that it comes down to transparency and the level of comfort for the individual. It's not as easy as it sounds to source out different people to do both. What was common in a lot of the work that we did was our company might do the clinical follow-up and the monitoring check-ins, but we had an independent third party conducting the random urine tests, for instance. But transparency and conflict of interest is something worth asking about and delving into. Yeah, it's a timely question because that is a topic of conversation.
Thanks, Darren. We'll keep them coming for now. How do you get an employee with mental health issues to accept help? Do you have any suggestions?
So typically the apparatus or the cause to refer an employee for an assessment would be based on observed behavior and performance related issues. The importance of documentation can't be underestimated. What I've seen done effectively is employers documenting behaviors, troubling behaviors, and diverting employees towards an assessment in lieu of disciplinary action as a result of the behaviors, and then falling back on the recommendation in the assessments. So if the requirement is that they follow the recommendations of the assessing professional, part of the assessing professional's job would be to gauge the individual's readiness for change and willingness to accept help. But yeah, I mean, we can document behaviors, and the behaviors documented would uh, necessarily dictate perhaps disciplinary action, which would the organizations I've worked with is what would drive the referral for assessment, and the requirement would be that the individual comply with their recommendations in the assessment. In a collective bargaining situation, the added wrinkle to that, and this happens. It's actually not that common. Is that if there was any issue of the employee or the union challenging the recommendations of the assessing professional, they would have the employee attend for an independent medical evaluation through a professional of their choosing. Even in a non-union environment, employees would have the right to do that. I mean, in my experience managing plans, that was the exception rather than the rule.
Fair enough. Darren, what would you say is the initial trigger for people who find themselves in a situation where they are turning to a negative coping mechanism, even outside of mental health? And this person says lack of control?
Could you ask that question again? Sorry.
For sure. What would you say is the initial trigger for people who find themselves in a situation where they're turning to a negative coping mechanism?
Well, I mean, there's no one answer to that. Um, what we hear from our patients, and what I heard from patients that were before me over the years, was that their gravitation towards unhealthy coping mechanisms, whether it's anger or it's alcohol, or it's sexual compulsive behavior, whatever it might be, was born out of stress management. And people tend to do what works for them. So if I don't have clear, well developed coping skills, and I learned in my adolescence that when I have elevated stress or social anxiety, that alcohol alleviates that, and alcohol begins to work. Um, that's going to be my go-to. We're going to go to what works. And for a lot of patients, describe that drift towards self-soothing through unhealthy coping mechanisms, response to uncomfortable feelings, really, stress, anxiety, um, like that. So then the solution becomes, any effective treatment program is about helping the patient acquire a semblance of tools and coping skills, so that, I mean, we're not teaching them not to drink, or not to go back to the old behavior, so much as we're putting new tools in their quiver, and providing them the grace of learning new skills and ways to deal with life, because there's always going to be difficult people, there's always going to be stress. But when our patients, after working with them for a couple of years, they come to me and they say, Darren, you know what? I now know today that no matter when I wake up, no matter what life throws at me, I'm confident that I can deal with it without drinking, without getting high, or without gambling, whatever my issue is. That's true freedom, right? I mean, that's what we want for our employees and for our patients, is to learn these new skills.
Thanks, Darren. I think we have time for one or two more questions.
Mhm.
So here we go. Is a non-medical staff member, for example, an HR manager, allowed to do a rapid test for an employee? Is that something you can answer?
I, I would defer to legal counsel as far as whether they're allowed, but what I will say definitively is I highly recommend against it. Um, any any sort of workplace testing really ought to be done by an independent third party. If
Okay.
you want these things consistently applied without bias, I just can't see how that would be defensible in a employment standards case, although I'm not a lawyer. It's commonly done though, and it's often done out of sort of naivety and ignorance, and in the interest of expediency. But I highly recommend against it. And I've been doing workplace testing for almost 20 years, but 17 years. So
Okay, Darren, I'll squeeze this last question in.
okay.
Is a 2-year biochemical surveillance typical? We are receiving significant pushback for self-disclosure cases.
For companies that are providing biological testing as part of a compliance monitoring regimen post-treatment, 2 years is typical. Um, a lot of more and more safety sensitive workers are longer than that. I think like some police, fire, doctors, nurses, pilots are doing longer. 2 years is typical. Um, if there's, I mean, if there's pushback, I think I would encourage a conversation around what does the broader scope of support look like. I've observed bargaining situations where, for instance, an employer was introducing random testing post treatment as part of a package that include increased access to treatment and increased willingness to pay, and other benefits. Um, Oddly enough, the pushback typically does not come from the employee. The majority I'm talking over hundreds and hundreds of people I've worked with who have gone into those sorts of monitoring programs. What they understand for themselves, the patient, is that accountability is our friend, and very rarely do they begrudge that 2-year monitoring. So there's a role, I believe, for education, because at the end of the day, why are we doing that? We're doing it to optimize outcome. We're not doing it to shame people or to punish people. So is it not in the interest of the organization and the employee and or the the union, of course, to optimize outcomes? But to just do random testing in isolation and not provide other post-treatment supports as part of that compliance monitoring agreement, I think is wrong and arguably ineffective. So check-ins with some sort of monitoring professional along with that, with a clearly defined contingency plan, would represent best practices in my experience.
Okay, that's all the questions we have time for. I'd like to thank everyone for attending today. If you have a question that we couldn't get to and that you'd like to have answered, you can contact Darren through his email on the screen. Thank you, everyone, and have a great day.